Dr. Arulprakash for giving his time. And he is a very, very friendly person. He is very knowledgeable and at the same time very humble and simple and down to earth kind of person. So thank you so much for coming for the Zoom webinar to share your knowledge. And about Dr. Arulprakash, he has completed his BDS and MDS in Ragas Dental College, Chennai, Tamil Nadu. And he was an associate professor in Rajas Dental College, Tirunelveli, Tamil Nadu. He has been a mentor and key opinion leader in MSDA implants, Israel. He conducted several pre-conference courses and lectures in implantology and in various specialty forums. Chief mentor for Nellai Dental Academy, which is exclusively training in implantology for the past 10 years. Copyright holder for Dr. Arul's 1237 Principle for Implant Planning. Passionate in teaching undergraduate and postgraduate students. Today's one such day is now sharing his knowledge for Dental Vriksha platform. Dr. Arul, the forum is all yours. Please carry on, Doctor. We are waiting to listen.
Okay.
Sir? You can carry on, sir.
Yes, sir. Yes, sir. Yes, sir.
Thank you.
Okay. Very good evening to all. In the evening, Sunday, no practice. After COVID, people are familiar with webinar. Previously, the Zoom is new for us after COVID. COVID invented us for a Zoom meeting. So I'm going to. I'm Dr. Arulprakash. I'm practicing in Tirunelveli district in a village. I'm a village practitioner. I'm going to share my experience about implantology in a few slides. This is my first slide. Whenever I'm taking a class or whenever I'm going for a lecture, this is my first slide. Half of you, what you thought in medical school will be wrong in another 10 years. None of your teacher know which half will be wrong. It's a famous quote by Sidney Bowell. This is an important slide. Why this is important? Because the probability of change in knowledge is frequently changes. For example, treatment modalities, it's constantly changing, 30 to 100%. 10 years back or 20 years back, a patient came to our clinic with a complaint of decayed tooth with pain. The treatment is extraction. Now the treatment is root canal treatment. Previously it was there, but many of the clinics are not equipped, or 20-25 years back in the rural areas, rural setup, they are not equipped to do the root canal treatment. The diagnostics, it's a frequently changes, 20 to 100%. Previously, conventional radiograph is there, then digital radiograph, OPG, CBC, now OPG, CBCT. Up to now, in another 10 years, we have another very good or very friendly equipped radiological as well as other diagnostic modalities. Biochemistry, some forward, and physiology and anatomy, very, very few changes. Why this slide is important? Because the anatomy of the mandible or maxilla will give the idea to where we are going to place the implant, how we are going to place the implant, how the anatomy of the oral cavity, how the anatomy of the blood vessels, how the anatomy of the nerves, which is very important to place our implant practice. Okay, next slide. Who can do implants? Only oral surgeon or prosthodontist or periodontist? No. This is only in the college. The three departments have a fight. I'm only doing the implants. You are not doing. Only the surgery people will do only the placement. The prosthetic people, they will send the patient to the prosthetic department. In our clinic, anybody, as per the Dental Council of India regulation, anybody who have the valid State Dental Council registration can perform dental implant surgery in our clinic. What are the things we need to know? We need to do in our practice. What are the knowledge, wide knowledge we need to know? In the oral surgery aspect, what are the things we have to know? First one is we have to know atraumatic extraction. Without atraumatic extraction, placement of implant will be complicated. If we break the buccal bone during the extraction, But when we are going for an implant placement, it will be a big challenge. In prosthodontic aspect, we have to know about how many implants we are going to place, how many how many tooth we are going to give, how many what type of prosthesis we are going to give, whether screw retain, whether cement retain, or how the occlusion will be, how the what material we are going to use for that particular case. These aspect we have to know, then we can place the implant. In periodontist aspect, we need to know some flap raising procedure, some grafting procedures we need to know before starting our implant practice. What is this slide? This slide, it's a famous Tamil comedy slide. எந்த ஒரு விஷயத்தையும் பிளான் பண்ணாம பண்ணா இப்படி தான். What plan பண்ணாம பண்ணா இதுதான். For example, if you are going for a failing to plan is planning to fail. For example, planning for an international trip. The bachelors, everybody want to go for a Thailand trip. Last year, I also went to Thailand with family. Okay, we need to. What are the things we need to plan? We need to plan. We have to valid passport, and we need to book the ticket, accommodation, visa, and sightseeing tickets. We need to book before itself. This is a planning for an international trip. Like that, we need to plan for an implant procedure. Okay, the improper treatment planning. I will show a case. This is a world largest bridge. See, 1, 2, 3 tooth. They take a 3 tooth as abutment. These long bridge. The dentist might know this bridge will fail someday, but maybe the dentist need a money for that month, or the patient not affordable for an implant, or the dentist not aware about implant surgery, or they don't have the well knowledge. Patient no consultation, no consultant in that particular area. So the dentist go for this kind of bridge. The dentist surely know this kind of bridge will fail in some day. This is an anterior aesthetic zone. What they did, they place an implant where the bone is available. They very labily placed implant. During that prosthetic phase, they have a very tough time. This is they place implant very close to the adjacent tooth. So in the anterior aesthetic zone, the tooth is not look like very aesthetical appearance. What they did, wherever bone available, they placed 4 implant and they give a straight abutment and give some prosthesis. This is an expectation, but this is a reality. Okay, this is a proper treatment. How to go for a proper treatment planning? I found a principle called Dr. Arul's 1-2-3-7 principle for implant planning. Using this principle, you can. This is not. This is a copyrighted one. Using this principle, you can identify the straightforward case. For beginners, you can identify the straightforward case. What is 1-2-3-7 principle? After placement of implant, we need a 1 mm healthy bone in the buccal surface, 1 mm healthy bone in the lingual surface. So if you want to place a 3.5 size implant, we need a minimum bone of 1 mm in the buccal, 1 mm in the lingual. So 5.5 width we need it. So this is a 1. After placement of implant, we need a 1 mm healthy bone in the buccal surface, 1 mm healthy bone in the lingual surface. This is 1. 2. After placement of implant, we need a space between the adjacent tooth and implant will be 2 mm. We need a 2 mm minimal clearance between the adjacent tooth and the implant. Why 2 mm needed? We have a periodontal ligament in the adjacent tooth which extend up to 1.5 millimeter from the tooth to the adjacent alveolar bone. So, if you rupture the adjacent periodontal ligament space or periodontal ligament fiber, it may affect the adjacent tooth. So, we need a clearance of 2 mm from the adjacent tooth. This is a 2. One is after placement of implant, we have a 1 mm healthy bone in the buccal surface, 1 mm healthy bone in the lingual surface. 2, after placement of implant, we need a clearance of 2 mm from the adjacent tooth. 3, inter-implant distance will be 3 mm. In the multiple implant placement, for example, if you want to place 2 implants, we need a minimum 3 mm clearance from the adjacent implant. So 7, mesio-distal width of single udangulus and interocclusal clearance will be 7 mm. If you need a 7 mm clearance mesio-distally and interocclusal clearance. Here mesio-distal width and interocclusal clearance. If a case fulfill all these criteria, it is called a straightforward case. Using this principle, you can identify the straightforward case. In the straightforward case, we can, all the beginners easily identify using this principle. You can do it straightforwardly in your clinic. Example, this is a case, we have a very good bone volume, we did a very good implant placement, it's a straightforward case. This is other case. If a case not fulfill the 1, 2, 3, 7 principle, it is called as advanced cases. All the full mouth cases are advanced case. This advanced cases needs some adjuvant procedure like ridge grafting, ridge splitting, grafting, or sinus lifting, or some other adjuvant procedure. Don't worry about all the advanced procedure. First, this is a class for a beginner. You can identify 1, 2, 3, 7 principle using a straightforward case. You can directly place the implant in your clinic in the initial phase. What type of case is this? We have a very good bone. It's a very good buccolingual width, mesio-distal width. So this is a straightforward case. So we opened the flap, we did a implant, we closed it. This is an advanced case. So we opened the flap, we placed the implant, we did some grafting procedure. Okay, what are the investigation required for implant surgery? It's a clinical examination. In a clinical examination, we need to know about any previous history of uneventful extraction or bleeding disorders, patient diabetic status, and patient hypertensive status, smoking habit, personal history. All these things will come under in the clinical examination. The main doubt will be whether we do implants in a diabetic patient. If the patient is in controlled state, we can do. In the smokers, it's a 1 or 2 cigarette is okay, but chronic smokers, it's not advisable for an implant surgery, whether it's a single implant or full mouth implant investigation. In blood investigation, we need to do complete blood count, bleeding time, clotting time, ESR. In radiographic examination, we have a 2D imaging and 3D imaging. 2D imaging, intraoral periapical radiograph and OPG, 3D imaging, CT and CBCT. Why 3D imaging is important? A 55 years female patient came to my clinic with a complaint of swelling in the posterior mandible. On examination, obliteration of buccal sulcus. In the intraoral periapical radiograph, multilocular radiolucency seen. So we send a patient for OPG. We have a multilocular radiolucency with root resorption. So we send the patient for a CT. We have multiple punched out radiolucency all over the cranium. This is a clear case of multiple myeloma. If we treat the case using the 2-dimensional imaging, we may trouble in a huge bleeding in our clinical practice itself. So we have to careful while if we seen any radiolucency or any pathological lesion, whether if you are accessible to the 3D imaging, better go with the 3D imaging procedure. The diagnostic cost, it will give a clue to how many implants you need to practice, you place, how many tooth we are going to give the patient, how the occlusion will be. What are the armamentarium needed? It's a physio dispenser. Physio dispenser is nothing but surgical motor connected with the saline connection. In a surgical kit, we have a lot of kits. It's a mini kit, advanced surgical kit, guided kit, prosthetic kit. Each and every company have separate catalog for all these things. You can follow any system, but keep it in mind. If you are going with this one system, you continue with the same system. because after 10 years we may we have trouble in getting the component. For example, I'm using Israel system are having the common component. The Korean system component may not be compatible with the Israel system component, so better go with a single system. Various marking drills, these are all the drills in the kit. Each drill have this 18 mm length or some. Each and every company have the catalog. We have a laser marking in the kit. In the drill we have 6 mm, 8 mm, 10 mm, 11.5, 13 and 16. I'm using a MSDA implant which is having the implant size of 6, 8, 10, 11.5, 13 and 16. So this implant drill also have the laser marking in this area. Yes, this is a hex driver. This is an implant driver which will useful during insert the implant and insert the cover screw. This is a ratchet. Using this ratchet, we will insert our implant into the bone. These are all various available sizes: 3.5 width, 3.75, 4.2, 5 and 6 widths are these widths the implants are available. The 8 mm, 10 mm, 11.5, 13 and 16 available lengths are there in our system. The implant will come in this category. We can take out the implant by using the mount. These are all the component abutment. We have two types of abutment. One is straight abutment, another one is angulated abutment. Straight abutment, angulated abutment, we have two types of angulated abutment. One is 17 degree and 25 degree. It's a healing cap. It's a transfer coping, analog. Okay, we need to know some anatomical factors in the maxilla. What are the anatomical landmarks we have to know in the maxilla? We have to know about the incisive foramen in anterior area of maxillary sinus, posterior maxillary sinus, floor of maxillary sinus, posterior area of maxillary sinus. In mandible, we need to know about that lingual artery. It's a very dangerous area, and incisive canal, mental foramen and mandibular canal. Why these landmarks are important? In the beginners, we need a 2 mm clearance from these landmarks is as a safe margin. For example, if you have a 12 mm bone before the below the sinus, we need to place a 10 mm implant initially to avoid we have a panic from whether we inserted our implant into the sinus or whether it's into the canal. To avoid all these things, initial period we may stop our implant 2 mm from the anatomical landmarks. So 10 commandments in implant placement. This is a 10 commandment. Treat the remaining tooth also. For example, if you are going to place an implant in 1/6, if the 1/5 is the distal caries or caries, you need to fill that also. Follow 1, 2, 3, 7 principle to avoid straightforward case. Avoid cantilever bridges. Take all investigations before starting the procedure. Keep all the instruments sterile. Plan before proceed. Keep the record for future reference. This is very, very important, because we may deal with many company implants during after 10 years patient may come, or 1 or 2 years patient may come. What type of implants we placed, what size we placed, all the things. If we have a separate record for implant patient, it will be helpful during that time. Use good quality material. For example, if you are going for a putty impression, it's a good quality of putty impression. Then the patient's review or patient visit will be reduced. Give proper instruction to the patient. For example, don't give the false promises. It will be there in your lifelong or lifelong guarantee. All these things may get in trouble, because in these times the patients are very aware about to complain in a legal cell. They are give a petition in us. So don't give false promise, all these things. Get a proper consent before starting the procedure itself. Don't give up any false promises. Don't make the straightforward case into the advanced case only by carelessness. This is a case. We have a dental caries in 1.5. So we restore the 1.5. After that, we did a flapless surgery. We take X-rays, replace the implant. Okay. Why I need to start an implant practice? It's a more than 97%. It's a more than 97% of success rate if you place a good implant in a proper way. It's more than a root canal. It's a success rate. So many of my students will ask during my class if a patient having the tooth. May remove the tooth and placing the implant is not at all right. As a practitioner, I'm saying root canal is a bread and butter. If you can save the tooth, the first choice is save the tooth. If you cannot save the tooth, you extract the tooth, wait for 3 months, place an implant. In another, mark my words, another 10 years, grinding the adjacent tooth will be crime. In before 10 years, if a patient came with a crown, if we have a high point in a crown, we can adjust the opposing tooth. Patient won't tell anything. And now the patient is very aware about all these things. Why you are grinding the opposing tooth, or I feel sensitivity, like that patient is complaining. So in another 10 years, mark my words, grinding the adjacent tooth only to replace the tooth without implant surgery, it may be a crime. Okay, financial benefit. In our clinical practice, we can't charge in more than a lakh for a patient other than implant. இது வந்து ஒரு தமிழ் படத்தில் இதெல்லாம் சொல்கிறத பார்த்தா இதை வந்து எனக்கு எங்கள் சார் சொல்லி கொடுத்தாரு. நான் அதனால் என் பாஸ் சொன்னார், நான் அதை சொன்னதுனால தான் நான் இங்கே இருக்கிறேன், என்னோட கார் வெளியே நிற்குதுன்னு சொல்கிறது ஒரு சதுரங்க வேட்டையில் வர்றது பொய் மாதிரி இருக்கலாம். பட் திஸ் இஸ் மை கார். இதெல்லாம் சொல்கிறது நம்புற மாதிரியாங்க இருக்குது. இதுதாங்க மனுஷனோட இது. இதை கண்டிப்பாக நான் ஆக்சுவலாக இம்ப்ளான்ட் in another 10 years, mark my words, another in 5 years, who are all not doing the root canal treatment as of now in their clinic, the patient thinks this is not a clinic. In another 5 years, they will think all the clinics are going to do implants. This is my clinic. Okay, how I will convince a case? Everyone will think I'm practicing in a rural area. I'm not seen any implant patient. Don't think about all these things. Patient won't ask for an implant. They will come for restore our tooth. We need to convince our patient to the implant surgery. How? When we will convince the patient? If we have a very good knowledge and very fully equipped about implantology, then only we will convince all the patient to the implant surgery. How I will convince? I am a private practitioner. I am a rural practitioner. I already told I am a rural practitioner. I placed more than 2,000 implants in my clinic. How I placed? What I will tell, many of the initially I started my practice in 2008 to 2014, I placed only 10 implants. That 10 implants itself, a consultant came to my clinic and they placed implant. After I realized why this was happen. Only 10 implants only I can place, because I don't have the knowledge how to place, what type of implant we need to place, how to talk to the patient, how to convince the patient. Previously, what I will tell to the patient, the implant surgery, it's a costliest procedure. Think about one thing. If a patient will think the dentist or a doctor will be a very rich person, if we itself saying it's a highly it's a இது வந்து காஸ்ட்லி ப்ரொசீஜர் அப்படின்னு சொன்னோம்னா patient will think டாக்டரே காஸ்ட்லின்னு சொல்றாரு, நம்ம எதுக்கு அதுக்குள்ள போகணும். Don't think about all these things. Another one thing, don't use the word is screw, or we are going to place a screw, or patient don't want all these things. For example, if a patient came to us to extract a 3/6, We are not telling the patient I'm going to give an inferior alveolar nerve block and open your buccal and lingual flap. I'm going to take a molar forceps and put it in your mouth. I'm going to break the, I will rotate. We are not telling anything. Why? Because we have a very good knowledge and we have a very good confident in extraction. So we are not saying anything. So in this procedure, after that, the past 10 years, how I will convince the patient? I'm not saying it's a costliest procedure. It is the word screw. I avoid the word screw. What I'm saying, whether you want to replace only the tooth or you want to replace the tooth with the artificial root. The word artificial root in Tamil is சேர்க்கை வேர். You want to place, we already removed your tooth. We are going to place an artificial root. ஒரு சேர்க்கை வேரை உள்ள எடுத்து வைக்க போறோம். உங்க வேற தூர எடுத்துட்டோம். சேர்க்கை வேரை உள்ள வைக்க போறோம். உள்ள வச்சு மேல பல் கொடுக்க போறோம். You want to replace only the tooth or you want to replace tooth with the root? Surely, mark my words, you will get a more than 10% of conversion rate. This is an orthopedic surgeon. One day I placed an implant for my patient and came back to my home. My brother is an orthopedician. He said, why you are so sad? I said, I placed an implant in 3/6. Patient have some, feel some numbness. Then he show a image. See, these much of implants I placed in a patient in a spinal cord, these are all motor nerves passing. You are feeling like this. Ana itna implant போட்ட நானே பயப்படாம இருக்கிறேன். See here, only one implant, you have only one nerve which is sensory nerve. You are feeling that much. So இது பிரச்சனை வந்துடும் பயந்தா எதுலனாலும் வரலாம். A simple infiltration can cause a life-threatening lingual hematoma. It's in my clinic itself. Only simple infiltration for root canal treatment leads to lingual hematoma. Some cases we cannot finish with implant. See this much of ridge. There are some other procedure. We have to accept all the cases we can finish it with the implant. This is a case we need to finish it only in bridge, crown and bridges. How much investment we need to start an implant? It's approximately 1,60,000 to start an implant procedure. We can get a minimum 18,000 we can charge. The implant cost around 3,000 to 4,000. The process is 2,500 to 3,000. This is a approximate process cost. Minimum we can charge 18,000. This is a 1.75 up to minimum of 1.75,000 per full mouth cases per arch we can charge. This is a consent form. I will share it in the group. You can download from this. Don't do a case without consent form. இப்போ இல்லைன்னா எப்பவுமே இல்லை. The picture itself says 1991 to 96 I think. அப்போ ஸ்டார்ட் பண்ணணும்னு நினச்சாரு, இன்னும் ஸ்டார்ட் பண்ணலை. இதே மாதிரி தான் நிறைய பேர் இம்ப்ளான்ட் ப்ராக்டிஸை ஸ்டார்ட் பண்ணணும்னு நினைக்கிறோம், ஆனால் ஸ்டார்ட் பண்ண மாட்டேங்கிறோம். எப்போவுமே ஒரு டீம் ஒர்க் வில் ஹெல்ப் யூ இன் ஆல்வேஸ். These are all my team. This is my clinic. Thank you, sir. Any doubts?
Very neat and very excellent presentation, sir. Very impressive.
Yeah.
And the forum is
Madam?
open for any questions now.
Madam.
So anybody wants to have any question, you can either directly and ask, or you can also post in chat box. Anyone with any questions now?
Sir, they can ask in the group, sir. We can. I will reply in the group itself, sir.
Yes. Now, if they have any doubt, let us wait for 2 minutes.
Yes, sir.
Anyone having any doubt, they can ask now directly, or they can post in the chat box now. And doctor, please tell us about your academy also, doctor.
Sir, we have a Nellai Dental Academy where Every year we will do 2 to 3 courses. It's a 3 days program. It's with the patient hands-on and live demo and dummy implant placement. Everything you can learn. Implant we cannot finish it in 3 days. You keep on learning. First, you will get a rough idea. You can learn. We need to attend many courses, many conferences. It will be helpful to upgrade your practice.
I think there's a question now in the chat box. So what about the diabetic patient, sir?
So diabetic patient, if the patient is control state, there is no problem. After osteointegration, the osteoresorption is very less. Many studies shows once the osteointegration is over, the resorption pattern is common for controlled diabetic patient as well as normal patient. If the patient on uncontrolled diabetic, it's a very high chances of failure of implants.
And one more question from my side, sir. So when do you consider it is normal, sir? If the patient says 220 is the random sugar level.
Sir, HP we'll go with HP A1C. If it's less than 7, we can go for it's a control.
The another question is, what will be the initial radiographic and blood investigation, sir?
Initial radiographic investigation, you can identify the 2D radiograph itself. We can identify the length. We have any gross pathology. If we can go for a 3D imaging, it's well and good. We can measure the implant, we can measure the bone width, length, and any pathological or any labial or furcation, labial in bone, any pathology, we can identify that in 3D imaging.
So Genesis active brand is recommended for implant practice. It's a question.
Any Israel company is well and good. All the implant will osteointegrate. Otherwise, it won't come to. They won't stand for a few years. I'm going with MSDA, which is Israel brand. It will give very good results as well as it will give, compared to other Israel companies. It is cheaper. So I'm a rural practitioner. I'm going with this.
So how you manage that hematoma case, sir?
Sir, that's the bleeding. When I was in UG, they said 4 P's to stop the bleeding. One is pressure, another one is pack, another one is pharmacological. 4th P is very important. Pray. Nothing we can do. That itself solved. That's not huge bleeding. It's not arrest the airway. So I escaped that.
Strawman, Noble Biocare, and Astom, which is best?
All implant is best. Depends upon the Strawman, the Noble Biocare and Strawman, which comes around 17 to 20,000 price. If the patient ready to pay, we can go. Depends upon this is a financial consideration. If the patient wants higher end implants, I'm not seeing any much difference in osteointegration and the final prosthesis, but Noble Biocare and Astom, they are very good in research and development. They are keep on updating their systems, and it will like driving a Benz car, but it's costly.
Sir, after implant fixation, how many days we have to? Sorry, I lost the question.
Wait.
Yes, sir. How many days we have to wait for replacing the cover screw with healing cap?
Sir, cover screw is 2 types, sir. If you have a very good bone implant contact, how much implant within the bone is a bone implant contact. Another one is primary stability. These two only decide whether we are going for an immediate loading or delayed loading. For immediate loading, we can do the day 1 itself. We can go for a directly in the healing cap. Otherwise, in maxilla, we can wait 3 to 6 months is better. In mandible, 2 to 3 months is better.
Doctor, so far, how many implants have you placed, and what is your routine review period for each patient?
Routine review.
Yes, sir. Review
Routine,
period for each patient.
sir.
Routine review period for each patient.
Sir, actually, what we inform to the patient, uh, you have to come for every 6 months for a cleaning. Otherwise, we won't. Otherwise, we are not responsible for the implant. But many of the patient won't come back. If they will come once the screw is loose and or patient have some pain or something, food impaction, after that only patient will come. We have a normally every 6 months we need to recall the patient, and we have to address the patient's complaint.
If bone loss around the implant, sorry, around the implant after 6 months, how to manage?
Sir, before itself, we have to assume if, in a non-extraction cases, we need to place the implant subcrustally. 1 mm, the initial minimal bone loss will be 1 mm. This is advisable. 1 mm is acceptable bone loss. We need to, how we can manage, we place the implant 1 mm below the crestal bone. This is after that, once the osseointegration is over, the very less chances are 0.5 mm. It's acceptable only.
So if there is severe bone loss, I'm just adding to the question, sir. And
Yes,
if
sir.
you see some severe bone loss, so how do we manage immediately, sir? Do
Severe
we
bone.
wait and fail till the implant fails? Should we wait, or should we do something to stop it, stop the bone loss?
Sir, this is depends upon the stability of the implant. If the patient have any pain, we immediately we can remove. We need to remove the implant. Otherwise, it will fail.
Okay.
If patient is asymptomatic, we can wait some more months. If the osseointegration is taken place, it's well and good. Otherwise, we need to remove and place an implant or other prosthetic. We have to go for other prosthetic options.
Another question is there, a difference between higher implant and lower implant, sir?
Higher implant, lower implant.
In the sense, maybe about the economical factor.
Yeah, higher implant. They are saying about Straumann and Nobel Biocare. They are highly chargeable implant. It's around 18 to 20,000 they are charging. The components are very costly. Maybe I don't know. Other than that, I am not sure about what is higher and what is lower. All implants have the ability to form the bone and osseointegration.
Reasons for stuck to cover screw, sir. The cover screw is getting stuck to the implant, I think. That's what the question is meaning.
Yeah, this first one, very subcrustal implant may have a bone around the implant over the cover screw may be stuck, or over tightening the cover screw will causes some thread in the thread in the cover screw also have the thread. The thread may damage or cold welding of that. For that we can go with the 5 Newton torque. If we give finish it with the 5 Newton torque, it will well and good. It will it won't stuck. It won't stuck.
So what is the relationship between smoking and the implant failure, sir?
Implant failure and, sir?
Smoking.
Smoking.
Yes,
Smoking, there's a normal 1 or 2 cigarette. The study shows one of patient who are having 1 or 2 cigarette per day smokers versus chronic smokers. Chronic smokers have more amount of periodontal disease. Like that, we have a bone. The periodontal disease is directly involved to the bone loss. Here also, the chain smokers have a more amount of bone loss. The implant will fail, may fail someday.
And normal torque value for implant placement, sir?
It's 35 to 40 Newton.
Cement retained or screw retained crown, which is better, sir?
Sir, it depends upon the available prosthetic space. If we have 7 mm, more than 7 mm, go with cement retain. Less than 7 mm, go with screw retain.
How to learn doing implants? Your advice, please, for a UG student.
So UG students, you need to know first we have to My suggestion: learn thoroughly with root canal treatment. Then, secondly, you can come to the implant, because I already told the root canal is a bread and butter. The implant for a luxury life, for the patient as well as doctor. Implant practice, you need to update knowledge. You need to attend more courses or more conferences, more lectures. You உங்களுக்கு அதில் ஒரு வெறி வரணும். You have because it needs a lot of money involved, more investments compared to other procedures.
And sorry, sir, it is high end and low end. The same question, sir. The implant, about the cost of implants, maybe high end and low end implants. And the another question is when to choose cement screw retained implant. I think you have answered already.
Answer, yes, sir.
Is there any formula, sir, for all anteriors you go with cement and all?
No. Sir, it depends upon the interocclusal clearance only, sir. So if we have a more interocclusal clearance, we can go with the cement retain. If we have if we have a access hole labially in the anterior area, we need to go with cement retain. Otherwise, the screw hole will be exposed anteriorly. Won't be aesthetically good.
Another question, sir. What is the youngest age we can place implants, sir? What we can start placing implants?
I will do after 18 years.
After 18, okay. Is there any specific formula or X-ray finding to check whether the bone is mature enough to place implants, or just with the age we can decide, sir?
Decide with this, sir?
No, any X-ray we have to take to check.
CBCT, we can identify the length, width of the bone. The quality of bone, we can't, there is no meter to this to evaluate the quality of bone. While drilling itself, we can identify.
Yes, sir. So what is your take on guided implants using surgical guides?
Surgical guides, as of my knowledge, if you have a very good bone, the guide will be perfectly placed. If you have a thin edges, we need to open the flap. We have to grind the crustal bone, then we need to place the implant. So surgical guide is not advisable for a very thin bones.
Can we take a patient with bruxism for implant prosthesis? I think there is a glitch. Is there a problem with the connection? Just give me 1 second. Let me check with him.
Sir.
Yes, sir. Please continue, sir.
Yes, sir. Yes, sir.
Can we take a patient with bruxism for implant prosthesis, sir?
Bruxism patient, we need to careful for bruxism patients, because more occlusal forces will be there. So better if you avoid a single implant for bruxism patients.
Okay. Sir, what is the adequate time gap between implant placement and prosthetic part placement?
3 months for 3 to 6 months for maxilla, 3 months for a mandible.
Okay, sir. There is one more question. When is the temporary prosthesis advisable right after implant placement?
Sir, if you are going for a full mouth implant, we'll give it immediately. If you can, another temporary now anterior region, A6 with a tooth, A6 retainer with the tooth. It will look like aligner.
Okay.
To see the patient. So this is very helpful in the anterior delayed loading cases.
Okay, sir. So any other questions, please? Or shall we close the day? So any more questions you can still ask in the group also. He's very much present in the group and he can answer you and
Yes,
guide
sir.
you. And sir,
Yes.
will also will share the consent form.
Yes, sir. I will share it.
Okay, sir. Thank you so much.
Thank you.
Blood investigations required, sir.
Blood investigation. We have what are the investigation we are needed for a simple surgical procedure extraction. That is self enough. Apart from that, we can get a calcium level, blood calcium level.
Okay. And there is one more question. INR value for implants in compromised patients.
In initial phases, in compromised patients, we can avoid implant placement. If the patient is fit for any surgical procedure, to get an opinion from a general physician or a hematologist, if they are giving for an opinion for a simple surgical procedure, we can go for that.
And reason for second molar implant failure in that region, sir?
For example, if we have a third molar, we need to remove the implant, remove the tooth due to over occlusal forces. Only the second molar. Majority of cases have failed in a second molar due to improper occlusal clearance or it's high points,
Okay.
improper prosthetic procedures.
Okay. If the required osteo integration doesn't take place after 6 months, whether the placing bone graft fastens the process?
No. After 6 months, it won't. The bone graft if the implant is within the bone, which is not osteointegrated, we need to remove the implant. We can't find whether the it's maybe failure of implant due to the not osteointegration or any contamination of the implant, any surgical procedure, any bone defect. We can't identify. We can't do it after 6 months. My opinion.
Okay. Can we place an RPD in between surgical and prosthetic phase?
Actually, in RPD we have instead of RPD we can go for a S6 retainer.
Okay. For premolar region, sir, same?
Premolar also. Premolar we can avoid if possible 3 months. After 3 months we can directly go for a posterior tooth. We can directly go for a permanent restoration.
Can we do implant and natural tooth bridge, sir?
No, sir. Because in natural tooth we have avoid that situation. If it's unavoidable, we can go. But my suggestion not go with root along with the root, because in natural tooth we have a periodontal ligament which gives cushioning effect to the tooth. It's not there in the implant.
Okay. Recommended bone graft collagen, any brand, sir?
This they have a collagen as well as graft also.
Is implant advisable in osteoporosis patients and patient on bisphosphonates?
If the patient's bone depends upon the mandible and maxilla bone quality. Patient osteoporosis, it won't affect all the bones. If the maxilla and mandible is not affected fully, we can go. But osteoporosis is in bisphosphonate therapy, patient may have a branch. Bisphosphonate associated osteoradionecrosis may come future. In these kind of patients, it's avoid the implant procedure is advisable.
Okay. Participants can also unmute themselves and switch on their video as well, and then ask a question directly. Or is it not? You are not able to do it. I don't know. I think it is open for everyone. Is there any implant which can be placed immediately after extraction, sir?
Any implants can place immediately after extraction, but we need to place, we need to prepare the area, the reason for the extraction. For example, if any lesion below the tooth, we need to cure it. We have to check there is any defect in the buccal and lingual aspect. We need to clean the area, and if any defect is there, we need to address by using graft and other collagen. We can place the implant immediately also, any implants.
And lot of thanks to you, sir. Thank you, sir. Thank you very much
Thank you,
for
sir.
sharing
Thank
your
you.
knowledge. And many messages are coming for
Yes,
thanking you.
yes, sir. I'm not fully involved in this because I'm in Chennai, IAOA, Indian Association of Oral
Ah,
Implantology Conference next
okay.
week in a COC meeting. I'm in the
Okay.
trade center.
Oh, okay.
So I
So,
can fully concentrate in this.
yes.
Sir, we'll do one more session
Yeah,
with
definitely, sir.
advanced procedure also. That
Definitely, sir. Definitely.
will have a team of our team itself will come there. We'll
Yes.
have a CBCT,
Yes.
how to read the CBCT and the surgical phase. We'll do it in another, in the Nalai Dental Academy itself. We'll do another program in our
Definitely, sir.
platform, sir.
Thank you so much, sir, for
Thank you,
your
sir.
time.
Thank you,
Please
sir.
concentrate on your work also. And
Thank
thank
you,
you
sir.
all the participants for active participation. So still you have any queries, we can ask in the group. So somebody has asked how to join the group. I have given the number in the chat. You can take it. So you can contact me personally. I'll add you to the group. I cannot share the link directly now with the laptop. Anyway, thank you so much for all the participants. And thank you, Dr. Arul, for the wonderful
Thank you, sir.
presentation and making
Thank
our
you, sir.
evening a great one. Thank you
Thank
all.
you, sir. Thank you, sir.
Bye-bye.
Thank you.
See you all the next Zoom meeting.
Thank you, sir.